Welcome to part 3 of evidence-based practice, documentation, informatics, and teaching, and we're going to focus on documentation. Documentation is a huge part of a nurse's day. Depending on where you work, documenting can be up to 50% of your daily activities or more. Our documentation is our best way of communicating all of the patient's information to all of the healthcare team. Most healthcare documentation is electronic now, called electronic medical record or EMR, but there are some places who still use paper charting. And of course, all electronic documentation has the potential to fall, and then you go into the dreaded downtime documentation, which is on paper. However you document, you must remember that everything you document is a legal record of all your interactions with the patient. It encompasses all of the nursing process, medications, diagnostics, and anything else related to the patient. Documentation helps with billing, research, evidence-based practice, and can help a healthcare system decide on what types of services to provide to the community. Because documentation is so important, we need to make sure we follow all of the professional and facility standards for how and what we document. Remember, if it wasn't documented legally, we didn't do it. So we must document everything. It needs to be a complete and accurate description of what we saw and what we did for the patient. We use objective data in our charting, and anything stated by the patient, we're going to type out in quotes. We don't write our opinions or judgments. We describe physical things, like the skin, exactly how we see it. We try to document as timely as possible. Real-time documentation is always the goal, but I know that we all get way too busy, and that isn't always possible. We also have to remember that documentation is confidential. We have to follow HIPAA standards when it comes to sharing any patient records. Although documentation takes up such a large part of our shift, it's very beneficial for healthcare providers. First, it helps ensure continuity of care among all providers. If I'm not available for another person on my team, they can look in the chart and find out all the information about the patient, allowing them to continue on with their work and not search for me. Electronic documentation saves time from having to handwrite so much. And EMR also helped minimize errors because of handwriting, because some of the handwriting was very hard to read, and if it got transcribed incorrectly, then the patient could die. It also helps us know exactly what we need to chart and what we need to look for. EMR is also required for reimbursement of medical costs, and most accrediting bodies require it for data collection and to show quality improvement. And then EMR also reduces our risk of liability. It helps us not be sued because we get everything documented. I will say that EMR became a little bit more overwhelming when the lawyers decided that we had to document every little thing so we didn't get sued. And I think that actually reduced the time-saving aspect of EMR that they claimed we were going to have. But honestly, I'd rather spend more time documenting than getting sued and having to go to court. When it comes to patients' rights and confidentiality, remember that patients have the right to see and copy their medical records. This means they have the right to see everything we wrote. This is another reason why our charting must be factual and accurate. They also have the right to see the names of anyone and everyone who looked in their records, so if you don't have a reason to be in the chart, don't look at it. The EMR date, time, and name stamps every person who opens the chart, so you can't look at anybody's chart in secret. This is part of the right to confidentiality. Confidentiality and HIPAA go hand in hand and are often thought of as the same thing. Confidentiality affects all information about patients written on paper, spoken aloud, saved on a computer, including their name, address, phone number, social security number, reason the person is sick, any treatments the patient receives, and information about past health conditions. Confidentiality breaches happen when healthcare workers don't pay attention to what they're doing or their surroundings. These breaches include any patient information that's on the screen of a computer or on an open paper chart. You want to act as if you have no idea who's looking over your shoulder. Emails and fax machines can send confidential information to the wrong person with one letter or one number being incorrect. So you need to follow your facility's email and fax guidelines before you share any patient information over email or fax. Even patient information that's printed out on a printer could violate confidentiality if you don't get it off the printer before someone sees it. We have to be mindful of what we throw away in the trash can because it may have a patient information sticker on it. A scary story of mine from when I was a new grad, well before HIPAA was a thing, is I had a difficult family member who would dig out IV bags from his father's roommate's trash can, and then he would hang that other person's IV bag on his father's pole and then try to blame it on the nurses, saying it was hung on the wrong patient. All of the patient information is on these IV bags. And the easiest way to breach confidentiality is by having conversations about a patient in an area that can be overheard by patients and families. This could be in the hallway, the nurse's station, the elevator, cafeteria, anywhere anyone could hear a conversation about a patient. Most EMR systems are very similar to their paper counterpart in which what got charted and how it's charted. When EMR first came to Phoenix in 2008, it was set up almost like they took the paper forms and made it electronic. It wasn't overly user-friendly, but it was better than handwriting everything out. We typed out our assessments in a narrative note or progress note fashion, meaning we typed everything out in full sentences like we were writing a story. Providers still document like this, but over time, EMR has improved for nurses, and we do more clicking of boxes than actual typing. We do still type some things out when we do focused or problem-based charting. And some EMRs have you chart by exception, which means you only document the abnormal findings, and then some EMRs make you chart your entire assessment. Most facilities' policies require nurses to chart their initial assessment, the plan of care, all the vital signs, and intake and output on flow sheets. And then, of course, the medications that you've given on the medication administration record or the MAR. And then document any follow-up assessments that were done. If the patient gets transferred or discharged, the EMR will have the nurses document that information as well. We also document all our family or provider interactions, whether it's in person or on the telephone. For times we have to document that a problem occurred, checkboxes won't always tell the whole story, so we're going to do some focused or problem-based charting. Different facilities want you to chart your focus notes in a specific manner. The three most common types of focus notes are the SOAP or SOAPier, PI, and DAR. SOAPier stands for subjective, objective, assessment, plan, interventions, evaluations, recommendation. So you would chart all of your subjective data, followed by your objective data, your physical assessment, your plan to fix the problem, your interventions, and any evaluations or recommendations you have. Sometimes it's early in a problem, so we just have the SOAP aspect to chart, and then later we add the SOAPier part into it. Another way to focus chart is with the PI format. Problem, like a NANDA problem, intervention, and evaluation. It's basically the same thing as SOAPier in a different format. Then lastly, we have DAR notes, data, action, response. Again, it's the same concept, different format. You would document all of your data, followed by what action you took, and then document the response to your action. For me, in the ICU, SOAP and PI were the two that I most used. Here is an example of a SOAP note for you to look at. If we had interventions and evaluations and recommendations, we would make it into a SOAPier note, but this one is just SOAP. And then here we have an example of a PI note, where we have the problem, intervention, and evaluation. And then here we have a sample of a DAR note, where we have the data, the action, and the response. So one important thing to know about healthcare and documentation is we use military time or the 24-hour time for everything. In documentation, it gets very easy to confuse 6 a.m. and 6 p.m. So we use that military time to make it a little bit easier to figure out what time we're talking about. Here's a picture of a military time clock. All of the numbers that are AM are in red, and then the PM, they turn black. How to figure out what number is what is we're going to take the time plus 12, and we do that for all of our PM numbers. So 1 PM would be 1300 because it's 12 plus 1. 1800 is going to be 6 plus 12, which is 18. Most smartwatches have a military time option, so if this concept gets confusing to you, turn your watch to 24-hour time until you get used to it. And I wanted you to know that EMR is not the only piece of technology we have in nursing. We have a lot in nursing, and the more critically ill your patients get, the more things they get. We have IV pumps, we have vital sign machines, we have bedside monitors, we have monitors that go inside the heart, we have monitors that go inside the brain, and we have so much more. The sicker these patients get, the more technology we use to treat them, which means we have more things to learn. And I have said to you several times already, nurses never stop learning, especially when it comes to technology, because we get so much newer and cooler pieces of equipment to play with. And this is the end of documentation.